It's always a pleasure to be able to come and talk about ideas that I think are important to people who are doing important work. And I hope as we go through, you can actually have a bit of a dialogue, and I really hope the film plays. Okay, we have one little short movie segment, so keep your fingers crossed. My name's the name on the slide. Some of us were talking about the Department of Mount Sinai, and it's a kind of a commune. So, in fact, anytime any of us do a presentation, it's thanks to a bunch of other people. In particular, Bob Monder, who's a close colleague of mine, has worked on these ideas with me, and Claire Payne, who's a trauma specialist at our hospital, was kind enough to supply a big whack of slides, and just completely ripped her off of a presentation that she did on Friday. So I'll try to make clear how that works. What I hope you're going to be able to understand today at the end is at least the data that illustrates that early childhood adversity has an impact on susceptibility to illness. Give you some sense of a model that we use at Mount Sinai for understanding that, not just understanding it, but working with patients quickly and easily in the moment when you don't have time to do a great in-depth psychiatric assessment. And utilize the knowledge that you can gain from the person's developmental history as an insight into the way they cope with things, and use that as they deal with the illness. Now, Anne talked about her time with me as a student. When I was a student at Mount Sinai in, I hesitate to say, 1986, Dr. Stephen Wu. Does that name mean anything to anybody? I choke up talking about Stephen. Stephen established the clinic. And I was a resident, so we started the clinic, and now this is what the clinic does. So last year they had 460 visits. They saw 109 new people in individual assessments, and they did a couple of family assessments. So there's a lot of work going on at Mount Sinai in terms of HIV work, and it's in place to support folks like you in the community that are doing similar work. Okay, what's the idea for today? The idea is actually an idea about evolution. It's an idea about adaptation. These are Darwin's finches. Everybody knows this story, right? That depending on the food source that was available, the finches developed different sized beaks because that let them exploit the environment. And the message is that environment shapes individuals, and that you can tell something about an individual by the environment they're in. And that stays with them, in many cases, lifelong, and impacts on how they deal with other challenges later in life, particularly the challenges associated with illness. Okay, so this is the other thing I cry about. Let's hope I don't cry about this one either. Here's the movie.
This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still phase experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age. And she gives a greeting to the baby gives a greeting back to her. This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing.
I'm here. It
good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Okay, so that's the still face experiment. That man is Edward Tronick. He works in Boston. That's a YouTube clip, guys. You can YouTube still face, and there's 3 or 4 versions of it. Everything's available on the computer these days. And I think, a picture is worth 1,000 words, right? I could give you a lot of data about developmental things with a lot of slides with things written on them. What you see there is that the mom and the infant are in a very tight symbiotic relationship. That's normal. The child is looking for the mother to be processing the kid's state of being all the time, and just simply amputating that communication, not being absent, but being present without the communication, is enough to freak out the kid. Okay? So when we talk about adverse experiences in childhood, I run the risk of kind of blending a whole bunch of different experiences. And I want to just make a point that this is not actually an adverse experience. This is an illustration of what an adverse experience could be if it was maintained. Okay? All the way up to frank trauma. And we'll be talking about trauma too. Okay? But it does, I think, sensitize us to just how reactive the little baby is and just how much impact there can be from developmental stages for a kid. Okay? Okay. So I'm going to, this is the part I ripped off from Claire. This is the adverse child experience study by Folletti. Folletti's a guy in California. He works for Kaiser Permanente, but they asked him to investigate patients within their HMO to find out who was going to be ill and whether they could predict who was going to be ill. And what he did was he asked them questions about adverse experiences in childhood, and a list of the experiences is there. It's a scale. There's a few more items on the scale. It is obviously retrospective, right? He's not getting the kids and then following them along. He's asking adults what their experience was as kids. But he's not saying, did something funky happen to you, or tell me how much that affected you. He's saying, was your dad incarcerated? Was there any drug use in the house? It's a yes or no question. You get 1 point. So if you were sexually interfered with when you were 5 by one uncle once, that's 1 point. If you're sexually interfered with for your whole adolescence by somebody else, still 1 point. Okay? So it's a yes or no kind of thing. And although we always worry about retrospective stuff, it is probably an underestimation in a lot of ways of what people's experience really was. And I'm going to hit you with a bunch of graphs because I want to make a point. And the point is the shape of the graphs, okay? So the axes didn't come out well here. But what we have here is along the x-axis, as you go to the right, we have more adverse experiences. So the first bar is 0 adverse experience, and the far bar is typically 6 or greater than 6 adverse experiences. And the y-axis is some measure of frequency. It might be odds ratio, it might be number of patients, might be percentage of patients. And as you can see, and in this graph, red is women and yellow is men. So the more adverse experience you have in your childhood, as an adult, the more likely you are to have chronic depression. Women more than men. Not surprisingly, the more likely you are to be prescribed an antidepressant, right? So this is 50 years after the adverse experience, and you're seeing people getting more psychotropic prescribing. When you look at a disease like chronic bronchitis, did anybody think chronic bronchitis would be related to adverse childhood experience? Who's a step ahead of me? What's the link? How does that work? Asthma. Asthma is one of those things, yeah. It's one of those illnesses, and you can see it's the same shape, right? As you have more risk factors, you get more odds of having that illness. Why would a kid with adverse experience be more likely to have lung disease? They're more likely to smoke. They're more likely to smoke. So one of the mechanisms for this is that the kids who have tough childhood experience are more susceptible to using the things that people use to calm themselves down. There's the big 5, right? There's tobacco, alcohol, drugs, sex, food. Okay? So when you look at the illnesses, stroke, same thing, probably smoking. Hepatitis or jaundice, right? This is a lot of hep C. This is a lot of probably sexually transmitted hepatitis. Smoking, okay? So you see that the kids that have this tough experience are more likely to have these risk behaviors and are more likely to manifest the illnesses that go with those risk behaviors. Let's look at some of the stuff that might be particularly relevant for your patient population. You look at people who are drinking a lot, same deal. If they define themselves as alcoholic, they're more likely to have had adverse childhood experience. Intravenous drug use, same deal. I'm just flying by these because the shape of the graph is always the same, right? And I want to make the point. So striking increase with intravenous drug use. So if you had a terrible childhood, you're 46 times more likely to be an intravenous drug user than if you didn't have an adverse childhood experience. Which means, of course, right, that some of the patients we're seeing are selected for having shitty childhoods. Right? We have to take that into account when we're seeing our patients. Teen sexual behaviors. This is the bars are the same thing, right? The low bar on the left is like 0 or 1 adverse experience. The high bar is more frequent adverse experience. Intercourse by age 15, teen pregnancy, teen paternity, greater likelihood of more than 50 sexual partners. So that hypothesis that we just generated amongst us here, that adverse childhood experience leads to these high-risk behaviors because they regulate your mood and your affect, seems to be borne out by the data. And in fact, when you look at the overall study, those are the risks that have been associated with this pattern, and those are the diseases that have been proven to be connected with this pattern. They just published something on rheumatological illness, hyperactive immunological illness as opposed to hypoactive immunological illness, and migraines. I think the message is, no matter what they look at, they're going to find this correlation, right? Because we're talking about folks that are stressed and having difficulty. So, what's the data? The data is if you had a tough time in your household as a kid, you're more likely to manifest adult illness. Notably absent is HIV disease, by the way. I searched HIV disease and I didn't find any data on this. But I find it hard to believe they have like 20,000 people in this study in California. They must have HIV data, but they haven't published it yet anyway, not that I could find. But you can see that some of the risk factors for HIV, intravenous drug use, more than 50 sexual partners, some of those things are in there. Okay, so that's the data on that we have quite straightforwardly on how crappy childhoods relate to later illness. I want to talk to you now about a related idea, which is how the experience of illness can exacerbate those kinds of feelings or those kinds of coping strategies. So this is a slide that we've used for 10 years to try to make this point. This is, anybody know what this is? This, ladies and gentlemen, is modern medicine. Okay, this is a picture that the Hospital for Sick Children used to brag about their new treatment, which was a croup tent in like 1926 or something, right? So this was them at their best. University Avenue, doing what we do. Does anybody look at that? Right, it's almost as disturbing as the still face, isn't it? Does anybody look at that and not think that that kid's having a tough time there? Right, in a tent, isolated, surrounded by machines, no people in sight, nobody holding his hand. Poor guy doesn't even have a teddy bear, right? He looks scared. So it's a bit dramatic maybe, but it makes a point, eh? Illness pulls out of us. Illness is a stress, it's a threat. Coming into the hospital is a threat. The medications we give for things like HIV change people in ways that they're not comfortable with. It makes them feel not like themselves. That's a threat. So illness pulls experience out, and whatever your kind of native, born in your developmental pathway coping strategy is likely to be pulled out of you as well. So this is the idea. You get a disease, particularly a chronic disease. There's a lot of uncertainty associated with it. There's a lot of suffering. There's enduring change in your body, in yourself, in your relationship, and how much you can work. And there are outcomes. And the outcomes are better or worse depending on how people manage those kinds of challenges. Now, if you do a psych residency, we can spend 5 years training you in models of personality or behavior. If you do psychoanalytic training, that takes a bit longer than 5 years, often. What folks at the front line need, whether it's psychiatrists like me going to the ICU to see somebody that might be just devented and can't speak that well, or in the emergency room when you go down, somebody's in crisis, or presumably in an intake in whatever settings you work with. You need something you can do quickly and effectively and yet is truthful, right? That has some veracity to it. And that's the question. The question is, how can we get a rapid fix on people's ways of coping? How can we understand them relatively quickly and use that in our communication style with them? And the answer in medicine historically is we give you a prototype. So that's a textbook case, right? So I suspect it applies in nursing and other disciplines as well. When we teach people about what depression looks like, we say this is what a depressed guy looks like. He's got low mood and he's guilty and he doesn't take pleasure in anything and he can't sleep, and that's what depression looks like. And then you go to the clinic and you see somebody, and the poor clerk asks those questions, and they get some of them, and they say, well, he doesn't meet criteria for depression. And the staff guy's going, he's depressed. Why is he depressed? Because it's a cloud, right? The actual typical prototype may not actually even really exist clinically, but it's a way of organizing what the symptoms are for people. And over time with experience, you get to know what the kind of manifestations of those are in real people. So I'm going to give you a few prototypes of something that's called attachment style, and we're going to think about it together. You can think of yourself. This is actually a self-rating scale for attachment subtypes. You can think of yourself. You can think of a patient that you have difficulty with. I don't mean a complicated patient. I mean a patient that makes you feel uncomfortable, uptight, worries you. You find yourself thinking about them after the clinic, right? That kind of difficult patient. Okay. And then we'll talk about how you can use that understanding of them to guide their management. Okay, so this is prototype 1. I find it relatively easy to get close to others, and I'm comfortable depending on them and having them depend on me. I don't often worry about being abandoned or about someone getting too close to me. Pretty good, eh? Prototype number 2. I find that others are reluctant to get as close as I would like. I often worry that my partner doesn't really love me or won't want to stay with me. I want to merge completely with another person, and this desire sometimes scares people away. So that's a kind of a clinginess. You're getting that vibe about a kind of a clinginess. Somebody wants to be in tight. Prototype 3. I'm somewhat uncomfortable being close to others. I find it difficult to trust them, difficult to allow myself to depend on them. I'm nervous when anyone gets too close, and often partners, particularly intimate partners, want me to be more intimate than I feel comfortable being. So this is somebody who's sort of the opposite of clingy, right? They prefer a little bit of interpersonal distance. Prototype 4. I'm constantly frustrated by partners. I feel the need to be really close, but then they screw me over and I get so angry I blow up. They can't understand me. When they back off, I get really scared of being alone, but even angrier that they're leaving. So this is a push me, pull you kind of thing, right? This is somebody who can't find an interpersonal distance that's working for them. So are these things feeling vaguely familiar to people? Is this reminding you of people you know or people you've worked with? Okay. So those are adult attachment styles, and they fall into the following categories. Prototype 1 is known as secure. About 55% of the adult population is securely attached. Okay? So that lets me make a point that I don't want to overlook. This is not pathology. Okay? These are various shades of normal, which is a tremendous advantage for a model like this, because you do not have to define somebody as nuts or personality disordered or crazy or something else in order to understand the way their relationship style works. In this room, half of us are secure and the other half are insecure, right? So look around, you know, it's a well-distributed thing. And we didn't get to choose it. We didn't get to choose it. We had the best fit we had with our parent. I'll get into that a little bit further. Prototype 2 is that clingy individual. That's known as an anxiously attached individual, about 20% of the adult population. Prototype 3 is dismissive. Dismissive refers to they dismiss the need to have somebody else close to them. That's the dismissing in dismissiveness. It's that they don't feel it. They tell you they don't need to have anybody close. And prototype 4 is disorganized. And disorganized refers to that kind of push me, pull you. It's like you're doing one thing, then the other thing, then one thing, then the other thing. It's not a constant, organized pattern. There are a million synonyms for attachment style. Child literature, adult literature, developmental psychologists, medical psychiatrists. It's a nightmare, okay? I'm going to stick with anxious and dismissive and disorganized, but I'm going to give you one other set of terms because they're so useful, okay? First of all, they're generated by John Bowlby, who invented this whole thing, and we should be respectful of our forefathers. And because they label the behavior so well. So the anxious individual is compulsively care-seeking. Okay, so they're care-seeking, they want to get close and evoke care, and it's compulsive, they kind of can't help themselves. So the illustration I always use for this, a clinical vignette, is a woman that came to see me. She had fibrocystic breast disease. Her mother died of breast cancer, so she's perpetually getting false positive mammograms, right? So she comes in, they go, well, I got a lump, got to put a needle in that, right? Oh, shit, I got cancer. My office is kind of a completely uninventive shrink's office, right? My desk is against the wall, and I pivot around my desk chair, and I got 2 chairs there, and I've got a coffee table in the middle that holds all the Kleenex, because you have to have a lot of Kleenex. And people come in and typically sit in one of the chairs, and we talk about things. So she comes in the room. Where does she sit?
Your chair.
Not my chair. I'm in my chair. Coffee table. She sits on the coffee table, and I have to move my knees like this because she's sitting right here. It's not a metaphor. She feels the need to be proximal, right? The emotional distance and physical distance is the same. She doesn't do that anymore, but that's the first presentation, right? It's, are you getting it, doc? I am desperately in need, and you're the guy to help me out. Okay? Okay, let's just take one slide about development, because I feel like if we don't do anything about development, it's going to be left kind of hanging for you. Again, rather than give you a lot of data, let's give you the kind of the metaphor. This is how Bowlby, I'm told, explained this. This is the metaphor of the barking dog. And what you have is a mom and a baby separated by a barking dog. The barking dog is a threat, right? It's scary. So the question is, what's the baby to do? So let's hear from you guys. What's the baby to do?
Baby's going to cry.
Baby's going to cry. If the baby cries out, Bowlby argues it's a secure kid. Why is it a secure kid? Because it believes that its cry will evoke a behavior from mom that will rescue it. Okay? Because it's a little risky to cry out. Okay? Right? So if it believes mom will rescue it, it'll cry out. So that's one behavior that denotes security. All right? So it has faith in the mom. That's the message there. What else might the baby do?
Shuts down.
Shuts down. Okay. So a baby that shuts down and just goes to ground like that implies that they don't really believe mom's going to come after them. Right? And it also implies that they can't do anything more active than just shut down. Okay, so that's a kind of a disorganized idea, even though it doesn't look disorganized in the moment. If you see kids in this if you really see kids in this situation, in a tested circumstance called a strange situation, they don't shut down like a sort of a doe in the woods shuts down. They fall to the ground, they writhe. They do what the psychologists call underwater movements, which are kind of choreoathetotic things. It's really disturbing. Okay, and it's like locking up the motor program. It's like they're supposed to be doing something, but they can't direct that in any kind of useful way, and they end up just having this kind of writhing thing. So that's probably going to be a disorganized kid if they just drop like that. What else might the baby do?
Move away.
Move away. So if my baby down there goes in this direction, what they're doing is voting with their feet. Okay? They're saying, I'm better off on my own getting away from this threat. It also moves them farther away from the mom. So we're not betting on the mom in this scenario, right? We're betting on ourselves. So that's a dismissive kid. That's a kid who says, I'll look after myself. I am compulsively self-reliant. Self-reliant is the idea. And off they go into the woods to get away from the dog, right? Mom maybe gets him, maybe doesn't know what's going on. What else might the kid do?
Approach the dog?
Approach the dog or approach...
Or maybe the mom? Maybe the mom would be better.
Well, the point is... You're so kind. Thank you very much. The baby can try to get to mom. And there are two paths to mom, right? One is a kind of circuitous thing, skirting the threat. That's a secure kid too, right? That kid is saying, I'm okay, I can do this, but I have to head to mom, right? So they have a sense that they can do it okay. But they have a sense also that mom will be there. And if mom isn't there right now, she'll respond once she clues in, right? So there's some faith in mom by that circuitous route. The kid who goes, I gotta get to mom, and runs right past the dog is my preoccupied patient, right? High intensity distress, can't manage it. Not the greatest strategy, right? If it takes you right past the dog, because you could get bit. Similarly, the self-reliant kid who runs away, not a bad strategy, but you're not with the adult. Actually, right? So you see these things make sense, but they're also potentially higher risk than the securely attached kid would. There's one other scenario, and the other scenario is the disturbing one. The other scenario is when the mother is the barking dog, and the kid can't figure out what to do. Okay, because they are obliged to approach mom. That's a embedded Darwinian selected behavior that all primates are born with, and most mammals are born with. And so their pull is to go to the mom when they're threatened. If mom is the threat, what happens is as you get close, of course, the threat becomes higher than the pull to security, and you want to back up. And that's that push me, pull you thing, okay? And you guys, I don't have to tell you stories from my clinical practice. You guys have all dealt with patients or individuals, clients, who can tell you stories of really abject, distressing things that happen with their parents or with their caregivers that create this kind of context. Simply put, in the moment, you can figure all that out from two ideas. One is, how do they feel about themselves, and how do they feel about the other person in the story? And the other person, the easiest person to use is you. Okay? So it looks like this. If they feel okay about themselves, and they feel okay about the other person, let's call that confidence in themselves and trust in the other, then that's consistent with the secure attachment. If they feel not too great about themselves, not much self-confidence, and they overdo the trust in the other, that's the anxiously attached individual. The dismissive person is the opposite. They're overdoing their self-reliance and diminishing, dismissing the need for the other person in the story. And the disorganized person doesn't feel good about either one. Okay, are we there? Because we're going to build on this now to understand individuals in a clinical situation. Any questions about that? Okay. So let's talk about how you use that to actually work with people in a clinical circumstance. We always start with secure as a kind of anchor point to contrast the other styles, but you don't really need any information from me about how to deal with secure people because they manage this kind of situation well, and you as clinicians know how to manage them well. It's not that they're not distressed, they might be highly distressed, but they're not evoking any difficult feelings in you. It's not hard to understand their circumstance. If you suggest an intervention, they may or may not agree with it, but they'll have a conversation with you about whether it's a good idea or not, and you can refine the idea, and you have a clear sense of alliance. You feel like you're working with somebody here, and you're both pointing in the same direction, right? You're rowing the boat in the same direction. That's a secure individual. The anxious individual is preoccupied with fear. That's the critical thing to recognize. That lady who comes in and sits on my table is frantically scared. The cover story is she's scared about getting breast cancer, right? The blatant story is she's been scared her whole life because of mistreatment as a kid and having to be precociously responsible for her mother's well-being when she was a youngster. And she didn't really know how to do that, but she could feel the responsibility for it. So she had a kind of a sense of always having to be doing more than she's doing and never quite doing it well enough. The sense is that she can't cope by herself. She needs the other person, right? And therefore evokes this kind of neediness that pulls the therapist into that story. So I'm trying to give you a couple little kind of visual things as we go through to help you remember these ideas. This is an old movie now, right? We keep talking about old things, but some of you from laughter, I think, remember it. The movie was about a shrink who goes on vacation, and Bob is the patient and pursues him, right? He's the ultimate clingy patient. And the point about the poster is that, first of all, Richard Dreyfuss is a shrink, right? So you see what he's doing, right? He's leaning back. Patient's leaning in, doc's leaning back, right? Because the patient wants to be closer than the doc wants him to be, than the doc is comfortable with, all right? That's the experience. And of course, the brilliance of this is that the shadows show you what the doc actually feels, right? Which is it feels like murdering the guy, right? This is not like a subtle feeling. This is like, get out of my face already, right? Respect my boundary. Back up a step, would you? Right? So what we hear about from the inpatient units, for instance, is, Jesus, John, she's always on the call bell. I can't get her. I go in and I check something, I get to the door, and they're just furious with the neediness of the patient, okay? Self-perpetuating cycle, right, guys? This is a patient who's actually terrified. She's on the call bell because she's trying to keep the healthcare worker in the room with her, but she's pissing off the healthcare worker every time she hits it and driving the healthcare worker away. So if you don't have some kind of appreciation of this, it's only going to get worse. Let's look at what the data is about these folks. A lot of this data comes from a guy called Paul Kiyosaki, who's a researcher in Washington on the West Coast and has done a ton of the kind of basic science to let us formulate these ideas. This is a bunch of diabetic patients and a different HMO who were organized by their attachment subtype, and they just looked at how much money they cost the HMO. What that really is how many visits they had. Okay, so the preoccupied, anxious, compulsively dependent, care-seeking individual is coming to the doc a whole lot more. So this is one of the ways that if you have a compulsive need for this kind of dependent link, that you can manifest a relationship, is you can complain about your illness to your healthcare worker. Okay? And who can say no? This is similar data. This is actually Hep C patients who come to the clinic, and the docs decide whether or not they have a physical symptom that can be explained. Okay? So Hep C is one of those illnesses, right? I don't need to tell you guys this. It's a serious illness. The treatment's a big deal, but sometimes patients subjectively don't feel a whole lot, right? But then they start feeling headachy or achy, or their bowel habits change.
I was going to say with Hep C, there's a lot of depression cases around that as well. Do you
Absolutely.
Believe, if they're on treatment with interferon, depression is very much a side effect.
Absolutely. So one of the points that raises is that this way of understanding patients is not instead of making formal diagnoses, right? This is in addition to making formal diagnoses. So if you have a Hep C patient who's on interferon and they got a rip-roaring major depressive episode, you better be paying attention to that. Don't just say, oh, well, they're dismissive individuals. You have to be working the whole thing together. But these are folks who are coming to the doc and presenting with a lot of symptoms that can't be explained, and we would understand that they are utilizing their standard behavior within the doctor-patient relationship and presenting this kind of neediness within that context. So what do? Certainly when you're in the hospital, it depends how long a relationship you're going to have with the individual. If it's a brief relationship, what you have to understand is that that individual is going to use you as an external modulator of their mood and well-being. Okay? It ain't going to change over the course of a week-long admission or a 2-month outpatient clinic stay or something else. That's the deal. They're looking to you to provide that function for them. And if you don't buy into it, you're going to get that self-fulfilling thing going on where they're upping the ante to make sure that you stay close. And you're pissed off with them and trying to divorce yourself from them. And it's just getting worse and worse. So most of the family docs know about this in town. When you say this to them, they go, yeah, all right. They don't necessarily like to do it, but they get it. The idea is that you have to see the patient before they signal you that they need to be seen. Okay, so you break the contingency between I complained, therefore you saw me. So if I want you to see me, I have to complain some more. And you see them independent of their complaints. So we would tell general medical floor at the hospital, what's the most frequent you can see that patient without driving yourself utterly crazy? And they'll say, well, we can pop in every 30 minutes. I say, okay, for the next day, pop in every 30 minutes, regardless of complaint. Just pop in every 30 minutes. Family docs will schedule them every 2 weeks. Schedule them first thing in the morning when you actually have some energy to deal with somebody. A set amount of time. And you entrain people into that kind of schedule. And what happens is that the desperate calls in between times fall down, and you end up actually having a kind of a consistent behavior. And then you can open up the interval a little bit, and the person acquires more and more independency. And remarkably, guys, you find that you actually start talking about the stuff that you want to talk about. Instead of talking about whether their nails are growing too slowly or, you know, their headache is bugging them, and you don't know. You end up hearing about, you know, the relationship struggle they're having, or the sense of loneliness that they deal with, or something else. Something you can actually work with as therapists. We would also, by the way, do anything we could to help them with their affect regulation. So relaxation training, maybe a short course of benzodiazepines around a procedure, for instance. You know, it's throwing somebody like this into an MRI or a spinal tap or something like that. That's almost cruel, right? You have to help them with that and figure out some way of helping them regulate that. It is often the case that they're very good copers. They just don't know it. So I stumbled because I was trying not to give you the data. The woman that I talked about before, her dad died when she was 8, and she was left with a mom who just completely decompensated. She was at least borderline and probably crazier than that. And she would say to this young girl, I'm going to kill myself. When you wake up in the morning, I'm going to be dead. And you know why? It's because you're such a bad daughter. Right? Incredibly cruel, nasty stuff. The patient doesn't experience that episode as high coping capacity. She experiences that as my mother was crazy and there was nobody there to help me. Right? So you can sometimes reframe, you can find these episodes and you can reframe it for individuals so they get a sense of their own capacity, not just that they can have to turn to the outside person. Interesting little study here. It was a dental procedure, and it was like wisdom tooth extraction or something, some sort of standard but awful dental thing. Says the man who goes to the dentist tomorrow night. And what they did was the next day they randomized patients. The next day they just called them up and said, "So how you doing? Any pain? Any problems? Just curious. Wanted to know. Hope you're doing okay." And the patients weren't warned that the call was going to come. And the patients that got the call, randomly distributed, reported much less pain and used much less pain medication than the people that didn't get the call. So it's a lovely little study, and I think the hint there is that indeed some sense of connection and affiliation helps people regulate some of these illness-associated symptoms. Okay, so the dismissive individual is that person who is compulsively self-reliant, right? That's this guy. It's a kind of an ideal, right? It's an important thing to recognize that when I say it's not these things aren't pathology, I mean it, they're not pathology. In fact, this one tends to be actually kind of encouraged, right? A man who's independent, who can look after himself and doesn't need anybody's help, that's kind of a value in our current zeitgeist, right? It's not actually a healthy way to live, but it's often supported. What this slide shows you is that if you look at diabetics again, and you categorize them by their attachment subtype, those are the bars, and you look at how good their diabetic control is. Basically, higher up on the y-axis is poor diabetic control. And that big red bar on the side there is the only one that is statistically different. And that consists of dismissive individuals who say they can't talk to their doctor. Okay, their doctor doesn't listen to them. Okay, so this brings, I think, to our feet the idea that relationship style, communication style impacts on very basic fundamental healthcare issues. That level of glycosylated hemoglobin is enough that that individual is going to get kidney failure before the next patient, they're going to get retinopathy before the next patient. This is like not good news. And our understanding of this is that they go in to speak to their diabetologist. And anybody diabetologist in the room? I'll shoot my mouth off too soon. Diabetologists like the numbers, right? They like the numbers. They want your blood sugar to be in control. That's their job. In my fantasy world, they go into the diabetologist, and the diabetologist says, "Oh, no, this is too high. You got to test more than this, man. You got to test like twice a day, and I want to see those numbers next week." Right? Because they're like intensely about about regulating the disease. And this patient goes, "Yeah, sure enough. See you later." And they just fade off, right? Because it feels too intrusive. It feels like they're crowded. It feels like somebody's telling them what to do, and they're independent, man. They're looking after it themselves, and they bail. We have data on this, again from Paul. He looked at the diabetics, and he looked at the dismissive folks, and he found out what their adherence was like in diabetic protocols. And they don't follow their diet. They don't follow exercise recommendations. They don't do foot care, which is a big deal in diabetics. And they tend to smoke more, and they're less compliant with their medication than patients that are securely attached. Okay? So it holds up, this idea that they're doing things kind of independently and are less in an alliance with their doc than some other patients. Holds up. This is a bit of a complicated slide, but if you bear with me, I want to go through it because I think it's got a couple of really good take-home messages. This is work that Jon Hunter, the fellow I said at the beginning, did. So we have the attachment subtypes at the bottom, okay? Dismissing one on the left. Adaptable would be secure, and preoccupied is preoccupied, anxious, okay? And we have, these are ulcerative colitis patients. They have inflammation of their bowel, right? And the people in the gray bars, when they're scoped, when you look in their bowel, they have inflammation. And the people in the white bars, when you scope and you look in their bowel, they don't have inflammation. And on the y-axis, we have the self-report, what the patient tells you their symptoms are, how sick they are. Okay? I think I have to run up there. Oh, I can't. Here, we'll do it this way. All right, so first point, let's take secure as our kind of average normal again, okay? First point is that when their bowel's inflamed, they report more symptoms than when it isn't. Well, that makes sense, right? That's the way, they got more symptoms, they got more inflammation, that's the way it's supposed to work. By the way, they're never without symptoms, because it's a shitty disease, and people always have, some diarrhea or some cramping or something. Okay, go over here next. Preoccupied patient, same pattern, but really amped up. Okay? So they're complaining, but at a higher level than these guys, statistically significant higher level. Okay? So that's what we've been saying all along. If you have this kind of need to be connected with somebody, you're going to use your symptoms as a communication vehicle. Okay, look at this here. The level of complaint between the secure people with inflammation and the preoccupied people without inflammation is the same. So if you're a doctor and you think you can tell what's going on in your patient's bowel by the level of complaint, you're pissing up a rope unless you know their attachment style, right? You have to know what that is. So this is an argument for what? This is an argument for continued care, right? This is not good for a walk-in clinic. This is not good for a clinic where the new house staff goes in every month and picks up a chart and goes, "So, how are you feeling today?" And the patient just thinks, this person doesn't know me from Adam, right? The doctor has to know what that patient's level of complaints was last time to be able to make sense of this. Last point, the dismissing individuals just don't complain. And in fact, this is not a statistical difference. Okay, so whether they're inflamed or not, they complain the same. Okay, so you can't tell with a dismissive individual what's going on. So that's why we like this model, because there's evidence to support that it really does make a difference. So what's the deal with these guys? The deal with these guys is you can't crowd them. You have to be respectful of the distance. This is the kind of person you're likely to call Mr. or Ms. So-and-so. This is a person, I make a point generally of not standing at the bedside because it feels too, power hierarchy kind of. But for sure, this is a person you're going to pull up a chair. You're not going to sit on the bed, right? You're going to pull up a chair, give them distance, and talk to them from a respectful distance. And you frame anything you need as a return to self-reliance. That's what they want. They want to not feel dependent. So you say, look, I know you don't want to have this test, but it's getting this test that will let us kick you out of the hospital, and you certainly want to be out of the hospital. So let's do the test, and you can get out. Okay, so you don't get into a power struggle about the test. You get into a kind of agreement with the patient about what's more significant, and that is restoring their independence. And you be as flexible as you can. I gave this talk, a version of this talk, a couple of months ago. And one of the people in the audience said, well, aren't you giving in to them? Right? And that's the countertransference. That's the, oh, God damn, this is my hospital, I'm running water. That's where the power struggle comes. What's giving in? Giving in is nothing here, right? It's just making the system work and appreciating that this person has got a shtick that they come by honestly, and so do we, right? So let's not get into the hassle with them. Okay, home stretch, guys. The most disturbing ones, of course, are the disorganized individuals. That's that push me, pull you, unstable approach avoidance stuff I've been talking about. And in fact, there are actually two versions of this, and it's worth understanding the two versions. The easiest one to get is this fearful individual. Think of somebody who's sort of pathologically shy. Okay, so they don't actually feel like they're okay coping on their own, but they don't actually trust that you're going to help them. So they end up being kind of alone at home, but really worried. So the clearest case lately of an individual I've had like this was a woman who presented way too late with her breast cancer, right? And I think it's because of this. I think it's because she really didn't feel like she could come forward with a kind of embarrassing, female thing to her doctor. And by the time she presented, she had metastatic disease, which was just too bad. The other way that people withdraw is they angrily withdraw, right? They say, fuck you, I'm not doing a thing. And they back up. It's angrier than the dismissive individual. Dismissive individuals often cool hand Luke about it, right? They're, I don't think so, thanks. Right? But these folks are, you guys are messing with me, I can't stand this guy. And they're angry, but they're pulling back as they're angry. That fearful person, that person who's kind of alone at home scared, is least likely to schedule a regular maintenance kind of health check. They have the highest frequency of missing those appointments when they do schedule them, and then the highest frequency of coming in crisis. So how to piss off a clinic, right? You blow off the regular appointment, and then you present needing kind of acute care. They can't manage their anxiety well, and so they get all avoidant, and then they will, in fact, show up later because it just gets to be too difficult for them. Colleagues of ours in South Africa got patients in the emergency room to fill out a self-report measure on attachment. And then after the clinical contact, the casualty officer was asked, is this patient difficult or not? How difficult are they? And here we see the fearful patients were considered the most difficult patients. Okay? They're hard to engage with. It's hard to feel like you're on the same page and that things are working well with them. Okay, what's that about? So these are difficult patients, and these are patients that evoke dislike in healthcare workers. Okay? So again, I'm trying to give you the tools to help you manage this. This is actually a picture that a patient of Bob's brought in, saying, this is who I am. This is what I've been trying to tell you about all these years. Okay? This is this guy's self-image. Okay? Disturbing, eh? I think. Like sometimes people laugh a little bit because it's so disturbing. But this guy does not consider himself to be human. He does not consider himself to be fit for human consumption. And he is really, really in a tough spot. So if you're that creature, how do you relate when you get something like an HIV infection? You need to see doctors a lot. You need to see caregivers a lot. It's a real struggle. And the ability to do it is beyond them, really. So that's why they're disorganized. They're trying this and they're trying that. They're trying this and they're trying that. And they have no reliable strategy for relating, and they're very difficult to reliably connect with or provide solace to. So what do? We try to make sure everybody is thinking of the individual as scared and distressed, not as an asshole. They kind of are assholes, you know what I mean? Like interpersonally, they're being really difficult, and you have to kind of acknowledge that too, right? Because otherwise, you're telling people they can't feel what would be normal to feel when somebody is rude to them, for instance. But really, it comes from a place of fear. And you also have to do a lot of staff support. So again, in the inpatient unit, we'd be more likely to spend more time in the nursing station than in the patient's office, in the patient's room with a patient like this. Everybody has to be delivering the same message. It helps not to have 5 different people talking to the patient. That's a general rule, but it particularly applies here. And the expression we found that seems to like anchor teams is your usual standard of care. Fundamentally, guys, the idea here is that we presume an alliance with patients, right? We think they're depressed. If I give them an antidepressant and it helps their mood, they'll tell me their mood is better, and that'll help me titrate the drug. They have a physical pain. I'll give them a narcotic. Their pain will go down. Their pain score will go down. They don't know how much narcotic I need or don't need to give them. And we have this kind of communication going back and forth. You do not have that alliance and that kind of communication with this patient. It's veterinary, right? You don't really know what's going on, and so you have to have some other guide. If you try to go by the patient, you're going to get as disorganized as they are, because one moment they're telling you to fuck off, and the next moment they're telling you they need you like they never needed anybody else before. And what sense can you make of that? So to stabilize it, you do what you do with patients that have this disorder. Right? If this is a post-op patient after a colectomy, we know how to do that here. We are, what's our expression? We're the best medicine. We're the best medicine. We know how to do, and you get people back in their sense of themselves as competent clinicians, operating in a sense, as it were, a little independent of the patient. Suicidality is an issue, and we feel strongly that you should use psychiatry when you need to, in a circumstance. Psychiatry is okay with suicidality. We deal with it day in and day out. We know what to do with it, even if it means certifying somebody and bringing them to the emergency room. And that's the kind of intensity that you're going to need help with, and you shouldn't be left kind of hanging on to that, managing it, and worrying about it on the weekends by yourself. That just isn't on. Okay? When we see patients like this, we tell them to bring in supports. Right? That's the idea about attachment. If there's somebody they actually do have some kind of reasonable attachment with, I've neglected that point. You can have different attachment styles for different individuals. Okay, so somebody can be disorganized with their mom, but anxious with their dad, for instance, right? And a lot of folks, when they get to be adults, they do have 1 or 2 people in their life that maybe we wouldn't identify as tremendously important people in their lives, but they're neighbors that show up and will look after the cat, and they're kind of consistent, and they're there. And you can ask them to recruit those people, because it's another set of ears that can help reassure them after the clinical content. Okay, so finishing up now, I want to get back to, because we're really talking about with those disorganized folks, we're really talking about folks who have been traumatized. This is not, they had a mom who did the still face on them for 2 minutes a day. These are folks that were sexually interfered with, were physically abused, were neglected, were mistreated. This was like bad news, okay? So we're talking about people really with complex PTSD from developmental stuff. And this is a study, courtesy of Claire Payne again, that did a meta-analysis on all the factors that impact on outcome in PTSD. And the thing that mattered most was the lack of social support after the event. So this is the hopeful statement. Even people that are really banged up and have had a terrible time, if we can provide them with social support, we can help them out. Okay? And that's the role that we all provide in the clinical work we do. So I'm going to give you a last illustration to try to give you a sense of this. This is a mother and baby, like we saw before. And this is the mental process. Okay, this is Paula Ravitz, another colleague. It used to be a dancer. And she does this. She says, the baby presents the mom with an emotion, like they're distressed and they're crying. The mom processes it in her brain and says, are you upset, sweetie? What's going on? She feeds that back to the baby. The baby processes that communication, and it goes in this kind of loop, back and forth continuously. The trouble with the still face is that it breaks that, right? That's the trouble with the still face. This is what's normally happening in a developmental sequence. And I would argue, guys, this is what happens in a psychotherapy or a patient contact. Patients want to know that you get them, you understand them, and they hear that from you, and they feel more secure because they have a sense that you get who they are and you appreciate their individuality. And then they feed that back to you with a sense of this is okay or it's not okay. And you have to keep refining that communication back and forth and back and forth. Never ends. Okay, so what I've tried to tell you is that early life adversity increases the risk of adult disease, but the attachment prototypes are a helpful way of managing it. Okay, and just at the end, I'll leave this stuff at the end maybe, there's a bunch of papers, and there's a book, because Claire Payne just wrote a book called The Hidden Epidemic, The Impact of Early Life Trauma on Health and Disease. And that's available for those people that want to pursue it further. Thanks for your attention.